And now there's a church right where I am, and I can hear the church bell ringing now. So now I know it's 4 o'clock. 4 o'clock Copenhagen time. And welcome everybody. It's January and 2022 has begun. And yeah, I can only hope for greater health and greater energy in the world this year for sure. So I'm Anne-Catherine, co-founder of Nordic Laboratories and DNA Life, where we focus on optimal health, health ownership, functional medicine, personalized medicine. Remember, you have your own account where you can look into all the tests that Dr. Brown will talk about today, the Metabolomics test, and also supplements, of course, and the videos, because the recordings from these webinars is in your VMS account as well. The next webinar we will be hosting is on the 27th of January on the new Trujac test, which is a test, a cancer screening test that checks for around 70 solid tumors. I did one. I don't have anything. So it's nice to know. And my family members did one as well. And cancer, do I have it? Don't I have it? Well, you just had a test, so you know you don't have it. That's really nice to know. So look forward to that. So, but the star of today's show is Dr. Brown, who has been presenting with us before on Metabolomics. He did a sterling job, but I thought it was time to follow up on his first presentation and also the second presentation that Graham did on Metabolomics. And then I cornered Dr. Brown and said, just give us a little bit more, spice it up a little bit, go into some pattern recognitions and give us some more details so that we can upskill ourselves, because that's all what this is about. Every day we need to learn new things. Every day we learn from our patients. We get ideas and gists as what we have to investigate, and we learn from the tools that we are working with, and we can only become better every day. And that's actually one of, at Nordic and DNA Life, one of our taglines is that we will always be better next year. So anyway, Dr. Brown has a doctorate degree from School of Naturopathic Medicine at Bacterial University in Seattle, Washington. And he also is practicing himself. He's in Scottsdale, Arizona. So I bet it's nice and warm where you are.
It is.
Yeah, you're very lucky. Oh, it's very cold and dark here, but anyway, so, but he's Genova's expert in regards to medical education as well. So Dr. Brown, I'm pleased to have you on board here for this webinar. Thank you very much.
Thank you so much for having me. It's a pleasure to be with you all this morning, this afternoon, this evening, wherever you are. I appreciate you taking some time out of your day to talk about the metabolomics with us. As Anne-Catherine mentioned, my name is Warren Brown. I have been with Genova almost 8 years, and I've been in clinical practice almost 10 years, and I rely pretty heavily on specialty diagnostics like the Metabolomics to make decisions about my patients. So I find it a very useful test to know about and to use in practice. And as Anne-Catherine mentioned as well, please check out Graham's presentation on the Metabolomics. I watched it, he did a fantastic job, and these were some of the topics that he covered in that presentation. And I included the YouTube link at the bottom of this slide. I will make my slides available to Anne-Catherine, and we'll share as many resources with you as possible. So great webinar. Graham did a fantastic job with that. So I thought I would follow up on that presentation and briefly talk about the conceptual framework for the test. We will cover interpretation, some pattern recognition, and some clinical application using a case. So we'll have a case-based discussion. And I will offer some additional thoughts on questions that were posed towards the end of Graham's presentation. I'll give you my opinion on alpha hydroxybutyric acid, omega-3s, and taurine. So for those of you who attended that presentation and had some follow-up questions about that, I've got a little bit of extra information there that I think may be helpful. And of course, I will share our interpretation resources, and we will have time for question and answer as well at the end.
Before you get further, I'm just going to mute everyone. So you have to mute yourself again, because sometimes they click off. So just hang on.
Sounds good.
So now everyone is muted, and you just need to unmute yours. Or I'll do it.
Okay, can you hear me now?
Excellent.
All right, great. And we have about an hour for this presentation, is that right?
Yes, something like that. Sometimes the Q&A takes a little longer, and yeah, but in that time frame, yeah.
All right, I'm prepared. I'm prepared for that. All right, excellent. Well, Graham talked about some common reasons for why clinicians order the Metabolomics. This is our list, but these are a lot of the conditions that that patients come to see us for. Fatigue, stress, chronic inflammation, mitochondrial dysfunction, mood issues, sleep issues, digestive issues. And then there are sort of lifestyle type of reasons for why you might consider this test. Patients who don't have the best diet, where you're trying to figure out, I can think of 15 different supplements for this patient, but what am I going to focus on? This test is really good for that as well. Sports fitness, patients who are just interested in optimizing and longevity, and patients who might have nutrient depletions that are secondary or tertiary to other clinical conditions, like a specialized diet or a medication or a GI surgical history, something like that. This is sort of the overview of what is being measured in the metabolomics: the organic acids, the oxidative stress markers, the amino acids, the essential fatty acids, which are optional as part of this test, and they're done from a blood spot, so a finger stick. And the nutrient and toxic elements, also an optional add-on. And we even have 4 genomic add-ons available. If you want that focused genomic assessment, you have 4 options to choose from there for just 4 SNPs. So in total, if you order the entire test, it's a little over 125 biomarkers. So a lot of data in this test. If you were to order the whole test and lay it out on a table, it would look like this. You would have 17 pages total. The first 6 would be interpretation at a glance. These are teaching tools that are really helpful for talking through test results with patients. We'll take a look at all of these as we go through, but then that's followed by the organic acids and the amino acids, the optional fatty acids, the optional nutrient and toxic elements, and the optional genomics. So that would be all 17 pages if you order the full test. Where does it get its name? The Metabolome. This is basically just a collection of the metabolites that are produced by cells during their metabolic activity. So it's kind of like a functional readout of that cellular activity. And this graphic on the right, which is poster size in my office, is a layout of the citric acid cycle, amino acid metabolism, fatty acid metabolism, and how all of that relates to each other. And all of these processes are happening inside cells and give us that readout, basically. So by looking at the organic acids, the amino acids, the fatty acids, that gives us this virtual biopsy of the metabolome, is how I like to say it. And the metabolomics sort of synthesizes all that information together and provides some summary information at the beginning, and then you get to see those metabolites throughout the report, which I will show you in a moment. Graham talked about this in a little bit different graphic. He had a little bit different graphic for this, but the concept was the same. There There are some things that we are measuring directly in this test, like DHA, which is one of the omega-3s that's really important for brain health and cardiovascular health. That is measured directly through the blood spot. So if we see the level low, we can correct it by giving DHA or telling them to get more fish, or diet or supplements generally. So a low level is pretty easy to identify and correct. There are functional indicators of nutrient deficiency as well. And this is the graphic on the right here. And if we're looking at a given metabolic pathway, like one of the pathways from the previous slide, we hypothetically here have A converting to B, converting to C in that pathway. That process is driven by two different enzymes, enzyme 1 and enzyme 2. When there is a nutrient deficiency that enzyme 2 is dependent upon, we tend to see an accumulation of metabolite B. And metabolite B is not converting very well into metabolite C. And that might show up as elevated methylmalonic acid in the urine. So you could look at that as a functional blockage in that pathway, presumably due to a lack of that vitamin cofactor that's required for enzyme 2. And so the Metabolomics uses both of these angles to try and identify where the nutrient needs are and what's going to be most helpful to the patient based on that. I often get the question, well, are these intracellular measurements or extracellular measurements? And there are some things that are intracellular, things like the citric acid cycle happens inside cells. Methylmalonic acid, the organic acids, these things accumulate inside cells. They're part of cellular metabolism. Essential fatty acids can be they're measured in part of the red blood cells. So there are some things that we're looking at that are happening inside cells, and then there are some things that are we think of as being extracellular, like the urine amino acids or the urine nutrient elements. So those things are measured more and thought to be more circulating levels of those things. So, and of course, the Metabolomics includes both of these. So we will focus on one clinical case here using the Metabolomics, and we'll use it as kind of a way to talk about how I work my way through the test when I'm looking at a test result. And I'll point out some things that I think are interesting here and try to include some of the most commonly asked questions about the test as well. And of course, there is this support guide, which I will provide the link for. There's over 1,000 literature references in our support guide. We call it the NutriVal and Metabolomics support guide. We combined both of those into one. And it's a great resource to have and tells you everything we know about the biomarkers. So I have a case here of a 59-year-old female. She is our patient for today. And her chief complaints were fatigue, anxiety, poor sleep, and she also had some gas and bloating that she was experiencing. So one of those typical functional medicine patients where there's not necessarily just one thing going on, but there's multiple issues that are contributing to poor health. She was eating mostly a Mediterranean diet, and she was heavily focused on fish. She was having fish 4 times a week, and her medications were pretty minimal. She was taking an antidepressant, an SSRI, and she had a recent course of antibiotics. Her supplements were pretty minimal too. It was just a multivitamin and some ashwagandha because she was reporting a lot of family stress and work stress. And she was trying to manage that. She was fairly active. She was doing yoga 1 to 2 times a week. I think she was walking quite a bit as well. So interested in health, doing some things to take care of herself, but there were some bases that were missing. And so if we look at that first page of her test result here, we can see at the bottom right that the toxic exposure had a pretty high significance here. And I'll zoom in on the bottom part of this first page here. And what we see here is that the toxic exposure, we gave her a 9 out of 10 according to our scoring system here. And partly because there was elevations in mercury and lead and arsenic. She even had elevation in cadmium. So there were some toxins present. We'll take a look at those in a moment, but that seemed to be a big issue, and that could have an impact on oxidative stress, because if there are toxic exposures, there could be more oxidative damage created from that. So oxidative stress also scored pretty highly as well. And then mitochondrial dysfunction and some other more minor issues. This scoring system here that you see on the first page is based on a weighted algorithm, and the algorithm takes into account how abnormal the biomarker is, and it also takes into account the strength of the evidence behind that biomarker. So it's a proprietary algorithm, but it helps you sort of get a sense of which area do I need to focus on the most with this patient. And you do get some insight into the algorithm, because underneath each score there on the page, you see the biomarkers that contribute to that algorithm. So there is some transparency there. The second page shows some nutrients that we think might help to correct some of those functional imbalances. So this is also algorithm based and comes up with recommendations for antioxidants, B vitamins, minerals, essential fatty acids, GI support, and amino acids. And there is space to make adjustments to these recommendations as you see fit. That would be the column on the right side of the page, which we leave blank so that you could write in a product name, or you could write in a different dosage, a higher dosage, a lower dosage. We always encourage you to take some liberties with our recommendations. We think our recommendations would help the patient, but sometimes it may not make sense to give a higher dose of something, or in some cases it may make sense to go quite a bit higher than what we recommend. So we encourage you to take some liberties with our recommendations. That was the second page. Oh, one thing I should mention. I see this pretty often in patients who have toxic exposures, or who are carrying a fairly significant toxic burden. I often see that the antioxidant needs and the B vitamin needs are pretty robust. And that was true for this patient as well. Most of these antioxidant recommendations are moderate here in terms of need. And then most of the B vitamins are moderate to high need. This patient also had a need for some minerals and some GI support too. And as we recall from that history, she was also having some GI symptoms, which might have been preventing her ability to digest and absorb some of her nutrients. One other thing I should mention about this page is at the bottom, we make some recommendations for amino acids. And if you see a 0 for an amino acid recommendation, it means the patient seems to be meeting their need for that amino acid. So if you see something recommended, in this case, glycine was recommended about 452 milligrams. It was because glycine was found to be borderline low or low in the test. And I'll point that out when we get to the amino acids page. But that's recommended here as well. And sometimes I get the question, well, do I need to give amino acids and digestive enzymes? And I think it depends on the patient, because some patients you could just give them enzymes and they will be able to get more amino acids out of the food that they're already consuming. So you may not have to supplement with amino acids. You may not have to tell them to increase their protein intake. You could potentially get more, improve their amino acid status just by giving them enzymes. So that could be an option for some patients. In some patients, you might prescribe a single amino acid, or you might tell them to get more protein. So there's several different ways you could go about doing that. The pages that follow are the interpretation at a glance pages. These are pages 3, 4, 5, and 6 of the report. And they are an elaboration on page 1 and 2. So they just go into a little bit more detail about page 1 and 2. And there are some key points about each nutrient listed here, an explanation of what that nutrient can do clinically, and the food sources of the nutrients are provided as well. And these summary pages are nice tools to have because they can help to explain the test results to the patient and help to keep the patient focused more on the clinical application rather than just giving a list of metabolites and sort of feeling compelled to explain every single metabolite. So this first part of the report allows you to focus on how do we address this clinically and what kind of foods might be helpful here, et cetera. And I'll zoom in on one of these pages where we will see the recommendation for B2 for this patient. So we can see it's involved in antioxidant functions. It plays a role in detoxification, just to name a couple of its roles. And it can be found in multiple different food sources. Those are mentioned at the bottom. That's the bottom bullet point underneath each nutrient in these summary pages. So a nice tool to have. And in some cases you might say, well, I'll just circle a few of those foods. I want them to get more broccoli, asparagus, spinach, not necessarily wheat or other sources. So you can pick and choose your sources, or you could use that as an opportunity to give them information about different sources. Page 7, 8, and 9 of the report are the organic acids. And so these are the metabolic byproducts or end products of our metabolism, our cellular metabolism. And this is really where we're getting that information about the virtual biopsy of the metabolome, because these mark those pathways for us and tell us about the potential need for vitamin and mineral cofactors. They are grouped into sections, as we'll see in a moment. But the reason why we do that is we want to we sort of group them into sections to try and get a sense of how efficient is that body system. And really, the nice thing about metabolomics is that it does help us to take a systems approach to trying to determine their nutrient needs. So the Kreb cycle page, which is the 7th page of the report, looks like this and gives us lays their results out in pathway format here, which helps us to visualize backups and pathways. And these could be backups due to a lack of nutrient cofactors. They could be backups due to toxic inhibitors. Excuse me. So an example of that would be, for instance, pyruvic acid being low, which was the case for this patient. It was borderline low, could be due to a lack of magnesium, which is an important cofactor upstream from pyruvic acid. That can be one thing. However, one other thing, and may not be the case for this particular patient, but you may see this in other test results. Patients on low carbohydrate diets may have a little lower levels of pyruvic acid or lactic acid, or patients on very low calorie diets. And it's because there are fewer carbohydrates coming into the system. That pathway might be a little less active if you're seeing that. So if you have patients if you see a lot of patients on low carb diets or keto diets, you might not see as much activity in that carbohydrate pathway. But the other possibility is that in a patient like this who was eating a Mediterranean style diet, she was getting some carbs, and a low pyruvic acid would be one piece of information that we use to help determine if she needs magnesium or not. There are some magnesium dependent cofactors and conversions in the citric acid cycle itself. And we can see here for this patient, there are some accumulations here. Cisacchinidic isocitric, succinic, and malic are all either borderline or high. And this could be nutrient related. Maybe she's lacking some of the iron, glutathione, B vitamins, magnesium, or manganese that are required to help drive this cycle onwards. Or it's possible that maybe her high mercury level and toxic metal load might be inhibiting some of the enzymes that make these conversions for us. So it's hard to know for sure, but it's not a bad idea to when we get to the treatment strategy for this patient, we'll talk about minimizing exposure and supporting with nutrients. And sometimes that's the key, because you can reduce their toxic burden and support them with nutrients that support detoxification. And you can always test again later and see how this is looking. Regarding those scores on the first page, most of the mitochondrial dysfunction score comes from this page, the upper part of this page, and most of the antioxidant or oxidative damage score rather comes from the bottom part of this page. And it's because the bottom part of this page, we measure things like lipid peroxides and 8-OHDG, which are oxidative damage markers. And that is a big contributor to our oxidative damage score on the first page. We'll take a closer look at those when we get to page 9. The malabsorption markers are the start of page 8 of the report. So we're working our way through the report here. So in the upper left of page 8, you'll see 2 malabsorption markers. These are the result of bacterial fermentation of tryptophan and phenylalanine. So indole acetic comes from tryptophan, phenylalanine leads to, when it gets metabolized by gut bacteria, it gets metabolized into phenylacetic acid. So the elevations in these markers might suggest that a patient may not be completely digesting their protein, because most of our protein is supposed to be digested and absorbed in the small intestine. However, if there's not enough enzymes or not enough hydrochloric acid, some of that protein escapes digestion in the small intestine, ends up in the colon, and can be metabolized by the gut bacteria there. So high levels could suggest that the patient's in need of some digestive support, and it gets interpreted as a need for enzymes on page 2. The bacterial and yeast dysbiosis markers, high levels of these could mean, in a patient like this, maybe there's some impact from her diet, because if she's got more fruits and polyphenol rich foods, you might see some happy bacteria producing some of these compounds as a result of that. And it may not be a sign of dysbiosis in every patient. However, this patient did have some gut symptoms. So this is also something you could see, these metabolites elevated here for the dysbiosis markers and the yeast markers here. It is something you could see in somebody with some bacterial dysbiosis or bacterial overgrowth, or yeast dysbiosis or yeast overgrowth. So I always think it's helpful to keep in mind the clinical history when looking at those dysbiosis and yeast markers, because occasionally you'll have a patient who says, I have no gut symptoms, my gut is perfect, I have no complaints, but I take resveratrol, or I have a berry smoothie every day. You might see some higher numbers for these metabolites, but that could just be a reflection of bacteria metabolizing those polyphenols, which is not a bad thing. So keep in mind the clinical context when interpreting that section. And if you're looking for more information about gut function, stool testing will give you a lot more detailed information about what's going on in the gut. D-arabinitol, I should point this one out in particular because this is a direct metabolite of Candida albicans. And so this is one that does have a fair amount of evidence behind it, and really it makes me wonder about the possibility of yeast overgrowth. And usually in my approach to this is I'll talk to the patient about making sure that they're not getting a lot of simple carbohydrates or sugars in the diet. And I might consider some Saccharomyces boulardii, which might help to compete with Candida albicans. Of course, Lactobacillus and Bifidobacterium could also potentially be helpful too, but when I see this one elevated, if the patient does not have strong yeast symptoms, I'll at least talk to them about making sure they're not overdoing it with carbohydrates. And I might consider adding in some Saccharomyces boulardii. So it's a useful marker. These markers here at the bottom left of page 8 are the same markers from the Kreb cycle page, the citric acid cycle page that we just looked at. However, there's one exception. So this one is pretty easy to miss, but it's alpha hydroxybutyric acid. It's the third marker underneath carbohydrate metabolism. There's really two things to think about when you see this marker elevated. One is that it can be a byproduct of hepatic glutathione synthesis, maybe indicating that the patient doesn't have enough glutathione. Maybe the body's trying to upregulate and produce more of it due to oxidative stress or just a lack of glutathione. So that's one thing. The other thing is this marker has been called a poor lifestyle habit marker because of its associations with metabolic syndrome and insulin resistance. So if you see high levels of alpha hydroxybutyric acid and the patient doesn't have a lot of toxic burden and the toxic elements looked perfect, then you might think, well, are there signs of insulin resistance elsewhere? Fasting insulin level may help you determine that, but it is a useful marker and it's gaining some momentum in published literature. The upper right side of page 8, we have the vitamin markers. And these would be elevations of these markers that would suggest a need for B vitamins in particular. So for instance, here we're seeing the glutaric acid elevated. Glutaric acid is an organic acid that tends to accumulate when we're lacking vitamin B2. So it helps to inform our recommendation for B2. It's one of several markers in the test that we assess in our decision to make a recommendation for B2. So a high level of glutaric acid would indicate the patient's lacking B2. The neurotransmitter metabolites, these are downstream metabolites of neurotransmitter synthesis and degradation, and they do tell us about altered neurotransmitter metabolism. However, that metabolism is driven by enzymes that have specific nutrient cofactor needs. Things like B vitamins, magnesium, and manganese. So we look at those neurotransmitter metabolites in that context. There are also some other things mentioned in our support guide about these neurotransmitter metabolites. I think the bottom line is we don't know if there's a one-to-one relationship between what we see in the urine and what happens in between the neurons. So I have a little hesitation in saying that this, if the serotonin marker is high, that serotonin levels are high in the brain. Reason for that is because most of our serotonin is produced in the gut. Some of it can be metabolized in the gut into this marker, into 5-hydroxyindolacetic acid. And the other thing is, sometimes this does make sense. For instance, this patient was taking an SSRI, and we can see here that her 5-hydroxyindolacetic acid here at the bottom right is at our upper limit, which is around 82. So it does make sense sometimes, but I think part of the reason why it is a little harder to say it's a one-to-one relationship is because of what happens in the gut and the fact that our gut can produce neurotransmitters. So there's more information about that in our support guide, but we still think they're useful, and we still find them very helpful for making the nutrient recommendations. This is what our support guide says about 5-hydroxyindolacetic acid, and it mentions specifically Antidepressants can cause a high level. It also mentions things like intestinal microbial balance is important. So you'll see a lot more detail about that marker in the support guide. The toxin and detoxification markers are at the bottom right of this page and help us to gauge their exposure to a couple of environmental toxins and gives us some information about the detoxification process. Pyroglutamic acid is the first marker in this section and helps us because it is a marker in the gamma-glutamyl cycle, which is one of the ways that we recycle glutathione in the body. So if we see this high, it could mean that there's either not enough glutathione around or that there's a toxic exposure, and that's causing the body to try and recycle its glutathione more quickly. So it's a useful marker to have. And an elevation in that marker would trigger our recommendation for things like alpha lipoic acid, which can help to recycle glutathione. The other one that's elevated in this particular case is alpha hydroxybutyric acid, and it comes from something called MTBE, which is a gasoline additive. It was used to boost octane levels, and here in the US it was used until the early 2000s. It's supposedly no longer used. However, it does have a long half-life in the environment, unfortunately. So it's contaminated groundwater. It's known to be an air contaminant too, so sometimes it's hard to avoid exposure. But our recommendation when you see it high are to think about things like water filtration, maybe air filtration, if that makes sense. But those kinds of things may help to cut down on exposure to it. But the other side of the equation is how do we support detoxification of it? And one useful pattern here is, it's a couple of other things to consider actually, are having the patient fill out one of the toxic exposure questionnaires. There are some that the Institute for Functional Medicine, I think they have one. There's one in the Clinical Environmental Medicine textbook that was published in 2020. And in the US, I even think the CDC has one that's accessible for free. So if you don't have a toxic exposure questionnaire, I find sometimes that can be really helpful. I'll have the patient fill it out, and I'll see if there's, if they had any occupational exposures that I wasn't able to find in their clinical history, or if they've got any hobbies where they're exposed to toxins. So sometimes those things can be helpful because if they're exposed to MTBE, they might have exposure to other toxins. So sometimes it can be a point that makes you think about other toxic exposures. So I think it's helpful in that regard too. What to do about it? Graham touched on this in some of his presentation. I thought he did very well. But hydration, making sure their water is filtered, because this is a common water contaminant, at least here in the US. And then the other thing is supporting with B vitamins, antioxidants, and amino acids if you're seeing that as a consistent pattern in other findings in the report. And one of the most common patterns I've seen with alpha hydroxybutyric acid in particular is that you'll often see this marker elevated with an elevation in glutaric acid. So glutaric acid is important in that first phase of liver detoxification. And well, vitamin B2 is, but the elevation in glutaric acid suggests that there's a need for B2. So in supporting detoxification of MTBE, you might consider B2 more seriously, especially if you're seeing that elevation in glutaric acid along with the elevation in MTBE. It's one of my clinical pearls for the day, but it is, think about supporting detoxification and minimizing exposure. Those are the main things to think about when you're seeing MTBE elevated. The oxalate markers are in the upper left of page 9 of this report. And these are basically, we're looking at oxalates or results of the glyoxylate pathway. And the one that I tend to focus on the most is the oxalic acid itself, because that has an association with calcium oxalate kidney stones. So it's the third marker in this section. If you're seeing that elevated, it could be the result of oxidative damage. Maybe that's from a toxin, maybe that's from a lack of antioxidants. It could also be the result of collagen breakdown. So from chronically high cortisol levels, we might break down our own collagen and muscle more quickly. Some of that could be metabolized into the oxalate pathway. And then, of course, there can be oxalates from the diet. And sometimes I get the question, well, if oxalic acid is high, do I need to tell my patient to eat a low oxalate diet? And I think in some cases that might make sense, particularly if they're doing a lot of raw vegetables, raw spinach, if that's a staple in their diet, if they're doing spinach smoothies every day, maybe it would make sense to shift them towards lower oxalate content foods, or perhaps steaming some of their higher oxalate foods. That tends to cut down on the oxalate content. So that could be something to consider. But there are things like bifidobacterium and lactobacillus and oxalobacter, things that we measure in the GI-effects profile that are bacteria that help to degrade oxalates. So I think you could look at high oxalic acid as an indication to either check their gut function further with the stool test, maybe make some dietary changes, maybe consider antioxidant support, or maybe consider checking their cortisol levels. So I think there's multiple solutions to the oxalate problem rather than just oxalates from the diet. Oxidative damage markers are here too. Lipid peroxides is measured here, which is evidence of oxidative damage to fatty acids. And 8-OHDG is evidence of oxidative damage to DNA. So if either or both of these are elevated, it's not a bad idea to think about some additional antioxidant support. I think this patient having some toxic exposures was doing pretty well in terms of oxidative damage, but I also think that's because her diet was pretty good to start with. She did have fruits and vegetables in the diet. So in some patients who aren't as careful with their diet, you might see a lot more oxidative damage from even less toxic exposure than for this patient. So just an interesting case here with this particular patient, but I think she deserves some credit for her diet. The amino acids are on page 10 of this report, and the left side of the page shows us the essential and the non-essential amino acids. And these are really the building blocks for tissues, hormones, enzymes, neurotransmitters. They do so much for us. So many structural proteins in the body are made out of these amino acids. So it's good to be able to see the levels here. And what I like to see is most of those essential amino acids towards the middle of the reference range. This patient was doing pretty good there. The non-essential amino acids did not look too bad either in this particular case. And I will talk about taurine. I think this was a good example of taurine too, which was also brought up in Graham's presentation. One of the questions was, well, if taurine is high in the urine, which is where we measure it here in the Metabolomics, do I need to check it in the blood? And I would say the answer is, I don't think so. And the reason why is if we think about the time frame that each specimen type tells us, when we measure amino acids in the urine, it's about 24 to 48 hours of history. So it's a fairly short snapshot. When we measure amino acids in the plasma, like we do in the NutriVal plasma, it is maybe a couple to a few weeks of history. But both of those are valid. Both of those measurements are valid. They both tell you the same thing about the patient's status for taurine. when you see high taurine, I think the first thing to think about is make sure that they're not supplementing with it, because you could find it in energy drinks. You could find it in detoxification formulas. You could find it in some digestive support products, those that have ox bile in them. Ox bile is bound to taurine. So that may be a source. If somebody has, let's say their gallbladder was taken out and they're taking supplemental ox bile with their meals, that might come along with a lot of taurine. So those are some possible sources that might explain it through supplements. However, it can also come from high fish intake. So if you have a patient who gets fish, in this case, this patient was having fish 4 times a week. So fish tends to be a little higher in taurine than some of the other amino acids, and that could explain an elevation. The other 2 things that you'll see mentioned in the support guide are sometimes you might see higher taurine levels in patients who have deficiencies of B1 or deficiencies of molybdenum. And that it's also found in the transsulfuration pathway. So if that's upregulated for some reason, like a CBS SNP, then you might see more transsulfuration metabolites. So there are a few little nuances that are mentioned in our support guide about taurine that go above and beyond just what's coming in from the diet and what the patient's utilizing. But I think by stepping back and looking at the bigger picture and saying, well, what was the need for B1? What was the need for the minerals? Those kinds of things can help you determine sort of which steps to take here. The right side of the page is used primarily to help us make decisions about B vitamins, to help us make decisions about magnesium. And these are amino acid metabolites in most cases, or byproducts of the urea cycle, or it's glycine and serine itself. And we did recommend some glycine for this patient. On page 2, when we were looking at those amino acid recommendations, we recommended, I think, a few hundred milligrams of glycine. And it was partly because the glycine level here was borderline low. And I think it may have some relevance for this patient. This is one where I might decide to supplement with some glycine because it can have a calming effect. She had a lot of stress, and maybe giving some glycine before bed might help with sleep. Glycine is also a precursor to the glutathione molecule. So it's important for making glutathione. And she did have some evidence that her glutathione was being recycled a little more quickly. So you could look at that glycine as something to consider to supplement with directly. You could do that with the essential amino acids as well. I'll mention 1 or 2 patterns before we leave this page, but those are just some things to think about and when you're looking at this right side of the page. The dietary peptide related markers here at the bottom right are intermediate steps between the protein that comes in through the diet and the amino acids that we ultimately need to break things down to. So it's kind of right in between. So if you see the peptide related markers high or close to being high, that could tell you that the patient is not completely digesting their protein, that there's a lot of partially digested protein present. And in this case, the dietary peptide related markers are kind of at the lower end here. And that just tells us that it seems like protein digestion is probably okay. However, there were some low amino acids, some low to borderline low amino acids for her, not severe, very slight, but it was enough for us to recommend some enzymes. And our algorithm takes into account low amino acids when it makes its decision for enzymes. So you might see normal to low peptide markers. You might even see perfect malabsorption markers on page 8. But if the patient has low protein intake or their amino acids are kind of on the low end of the scale, you might see an enzyme recommendation on page 2. And how I parse that out clinically is if I see an enzyme recommendation on page 2, I'll ask the patient, are you feeling any fullness after meals? Do you notice any undigested food in your stool? Those kinds of things, because if they do, then I'm more inclined to give those enzymes or order a stool test. But it's just a nuance. I wanted to give you a little bit of insight into the algorithm and how that enzyme recommendation came about on page 2. So digestive enzymes are sometimes recommended when we see low amino acids. But in this case, I think protein digestion wasn't terrible here, and there's not a lot of evidence of protein maldigestion. And so I think the moderate recommendation for enzymes could be worth considering. She did have some gut symptoms, so maybe worth a try before ordering a stool test or just going straight to a stool test. Page 11, we're looking at fatty acids here. And this is optional in the test. So if you order the Metabolomics with the blood spot, the finger stick for fatty acids, you will get this page. They'll have to prick their finger and collect a few drops of blood. The omega-3s, 6s, and 9s are reported here in the upper part of the page. And I think the easiest way to get a sense of these 3s, 6s, and 9s is to look at the percentage at the bottom of each category, where you can see the percent omega-3 was not looking too bad here. The percent omega-6 was actually kind of closer to the lower end, I think, because she was getting a lot more omega-3s in the diet than most folks. And then the omega-9s were pretty robust. Those usually come from olives, but they could come from almonds, or even sunflower seeds have some omega-9. So not looking too bad for this particular patient, but it is good to see these because they do play a role in regulating the inflammatory response and fighting chronic inflammation. And they've been studied with cardiovascular disease, autoimmune disease, mood disorders, neurological conditions. So it's good to be able to see those omega-3s, 6s, and 9s really quickly just by looking at that percentage. You can also see the saturateds and the monounsaturateds and the cardiovascular risk markers. So the saturated fatty acids, the percentage at the bottom of that category for this patient was borderline low here. She wasn't eating a lot of saturated fat, so that made sense for her. Does she need more? At this level, I don't know if the answer here is more, but maybe it wouldn't be a bad idea to add in a little bit of coconut oil. Usually saturated fat comes into the diet along with cholesterol. Cholesterol is the backbone for the steroid hormones. So maybe a theoretical concern with very low saturated fat, but maybe something to think about for some patients with low hormone levels possibly. Although I would expect it to be a little bit lower than that if it were preventing her from making steroid hormones. The monounsaturated fats, usually these come in the diet through nuts or avocado, or can even come from in the diet from dairy. A lot of folks forget that dairy has some natural trans fat in it. So that can be a potential source if you're seeing a patient who's consuming a lot of dairy and their trans fat marker is elevated. And then of course, the cardiovascular risk markers, the omega-3 index is probably the one that has the most weight behind it in terms of literature out of any marker on the page. So this one always is worth looking at. The omega-3 index looked really good for this patient. The literature says above 8 is ideal. And she's pretty much right there at 7.9. And I think this had a lot to do with her fish intake. But the omega-3 index is, you can see in our support guide, we mentioned some of the work from Dr. Harris and Dr. Von Schacke. These are a well-referenced marker and has a lot of weight behind it in terms of published literature. And in patients who aren't consuming a lot of fish in the diet here in the US, I often see this somewhere around 3 or 4. And ideally, we want this somewhere around 8. We also show you the fatty acid metabolism in the following page. It's the same markers from the omega-3s and 6s, but we report them in pathway format where you can see the enzymes that drive each of these conversion steps and the nutrient cofactors that are required to support those enzymes. There's also a reminder here that dihomogammalinolenic gives us some anti-inflammatory benefit from an omega-6 standpoint. And if you're thinking about prescribing GLA or gamma-linolenic acid, like evening primrose or borage or blackcurrant oil, you can see that's measured here as well, gamma-linolenic acid. So often we give gamma-linolenic acid when we're trying to support dihomo, since we can't supplement with dihomo directly. The body has to make it. So sometimes the answer is giving its precursor, sometimes the answer is supporting the cofactors in order to get more dihomo. Wasn't an issue for this patient, but in patients where we're trying to fight autoimmunity or chronic inflammation, that can be a pathway that we can manipulate to help the patient. The urine elements are optional, so you can order just the left side of the page or just the right side of the page. I'm sorry, you can order just the left side of the page or both the left and the right side of this page together. So you could add it on either way. So if you just want to look at the nutrient elements just want to look at the toxic elements, you can do that. But if you want to look at both, you would add on the comprehensive urine element part of the test. These are measured in urine. So generally speaking, these are a pretty short exposure history, maybe up to 48 hours. There are some exceptions to that though. And this patient had I believe had a history of a gadolinium contrast MRI years back. So gadolinium is one that for some reason can stick around for quite a long time and might be excreted slowly over that time period in some patients. And I've seen test results where patients have had a gadolinium contrast MRI, 2, 3, 5 years ago even, and their gadolinium is through the roof here. And I'm not sure if that's because it's stored in the kidneys or if it's stored somewhere else and it's just being gradually released. There are some unanswered questions there. Here in the US, unfortunately, can also be a water contaminant. So that may be something to think about depending upon where the patient lives. But it is one that I would say may be an exception to the rule of generally this being a short time frame. The other thing to think about is a lot of those toxic elements can come from seafood, not just fish, but shellfish or seaweed. And then of course, occupational exposures and other environmental exposures, air, food. Sometimes they're hard to track down, but we do have an extensive table in our support guide where we go into a lot more detail about those. So that's something to keep in mind. The other thing that's interesting here, and we're seeing this for this patient, it's not too uncommon to see, is that the nutrient elements were also pretty high here. And in patients who have high nutrient or nutrient dense diets, it's not uncommon to see some pretty high nutrient elements in the urine. However, the other times that I've seen very high nutrient elements are when the patient is lacking B vitamins. I suspect that there may be scenarios where they're wasting some of those nutrient elements. And just as an example, if we just go back to this fatty acid metabolism chart, we see the delta 60 saturase, the elongase enzyme, all of these enzymes require a combination of nutrient elements like zinc and magnesium and B vitamins and vitamin C. So if we're lacking some of the cofactors, could that put us in a scenario where we can't utilize some of the mineral cofactors as well? There's not a lot of published literature about that concept, but it may it seems to make sense because often you'll see high nutrient elements in combination with unmet needs for B vitamins. So it may be something to think about. And in my opinion, it's not always a situation where I'm saying, well, we need to dial back nutrient intake. I think it's really more of a utilization issue, probably most of the time. I won't spend too much time on the genomics, but this patient did have a COMT SNP. She was homozygous, and that could be impairing part of the second phase of liver detoxification, maybe part of the reason why she had higher B vitamin needs. We know that she was homozygous for COMT. So the treatment plan here, lower the toxic burden of the patient. We wanted to diversify her protein and fat sources because we think maybe the fish that she was eating, or maybe, for some patients, I think having fish that many times a week, may be a source of toxic elements. And of course, the source matters when it comes to the fish and the type of fish. But that was something to maybe address with this patient. We wanted to counsel her on less toxic seafood choices, basically. Switch her to a higher quality multivitamin. She was taking just an over-the-counter multivitamin, and so we wanted to switch her to a professional grade multivitamin, one with the active form of B2. That may help this patient because she had a particularly high need for B2. And considering glutathione support, anytime there's toxic metals, that many in particular, it's not a bad idea to think about what can we do to support glutathione. 500 to 1,000 milligrams of glycine, which is more than what we recommended here on page 2, but it's okay to take some liberties with the dosages. So, we're saying 500 to 1,000 milligrams before bed because that can have a calming effect. It might help her sleep, but of course, because it's a precursor for glutathione, and it's one of the amino acids that we conjugate things to help support detoxification, it makes sense for a few different reasons here. So it's a case where we're going a little bit higher than what's recommended for glycine. Continuing to work on stress management, of course, stress impacts every body system, but helping encourage her to explore those resources to manage her family and work stress. Continuing her yoga practice, that's a great idea for stress management and for movement. Movement is good for circulation and detoxification and so many different things. So continuing her good work there. And then rechecking the metabolomics in 6 to 12 months is reasonable for most patients, and I think reasonable for this patient. So that would be a reasonable interval to repeat the test. Of course, you could say the next step here is a GI-FX stool test to try and get to the bottom of the gut function issues, but that is another option. Maybe you could do that in the meantime. A couple of other common questions I should mention here. So generally the follow-up interval for the metabolomics is 6 to 12 months. And a big question I'm sure many of you have had is, should I test my patient on supplements or off of supplements in a follow-up test? So our policy is that we never recommend any patient to discontinue anything that's medically necessary. That decision is up to you and the patient. But that, sometimes it's helpful to see how those nutrients are impacting that patient's physiology, how it's impacting their biochemistry. So you might test them on those supplements and then look for gaps and see the clinical impact of those supplements. So that could be another possible approach. These were the genomic add-ons. I just wanted to include one slide in the deck just in case. And then here is a comparison between the Metabolomics and 2 of our other popular nutritional assessments. And the deciding factor for many clinicians, especially since the pandemic started, was I need an assessment that the patient can do at home, where they don't need to go in and have their blood drawn. And that would be the Metabolomics. A NutriVal cannot be done at home. The ion cannot be done at home, but you can get everything we looked at here in the Metabolomics. The patient can collect their specimen in the convenience of their own home. So that is the big deciding factor for a lot. But you can see there's a lot of overlap between the Metabolomics test and the NutriVal, and a lot of overlap between the Metabolomics and the ion as well. Before we get to your questions, I want to mention that quality is something we take very seriously at the laboratory, and we are licensed by all the federal and state regulations. We participate in internal and external quality assurance programs. So we have a list of proficiency regulations that we meet, standard operating procedures, and we put a ton of effort into making sure that we can give you the results that are reliable and you can make decisions from. So extensive quality controls is something that's always been important to Genova, and we are not letting up on that. I promised some additional educational resources. You can find them on our website at gdx.net. We have the support guide, of course, video modules, archived webinars. The podcast with Dr. Chapman and Dr. Devers is a more lighthearted, funner approach to learning about functional medicine and some of our testing. And then, of course, in the US, we have phone consults. So those are some of the resources available to you. I want to thank you so much for your time. I see we still got quite a few people on the call. That's wonderful. Thank you so much for your time. I really appreciate that. And I am more than happy to entertain some questions if there are any, and Catherine.
Yeah, I have tried to answer a few on the during your talk, but a few came up that I thought I was going to ask you about. Some of them are on comparisons, like if you measure amino acids, like what's best to do it in blood or in urine.
Amino acids in blood and urine, it really just depends on the time frame, and keeping in mind that time frame can be helpful. I think also if you have patients who have inconsistent diets, like they're not getting the same amount of protein from day to day, then that would be something to keep in mind when you're interpreting the metabolomics, because if they're the type that only has protein once or twice a week and they're testing 3 or 4 days from their last protein intake, you might see very low amino acids. The way I get around that in my own practice is I'll tell my patient to just keep a few notes about their protein intake in the day or two leading up to the test. And most of the time it's just an easy way to say, okay, well, your protein intake wasn't very good a couple days leading up to the test. That's why we're seeing these low amino acids. If that's not your norm, then we have an explanation for it. If it is your norm, then we need to work on increasing protein intake. So on our website, we will list for patients with mood disorders or patients with inconsistent diets that you might favor the NutriVal plasma or measuring the amino acids in plasma, because it will give you a longer average for their amino acid status. So that is something to take into account, but just having them keep a few simple notes about their protein intake. Did they get protein with every meal? Was it a little bit of protein, a lot of protein? That kind of information can help you get around that issue of feeling like you have to see the amino acids in plasma.
Super. The same question came up on fatty acids, actually. Plasma, red blood cells, blood spots, when to choose which. I mean, clearly, if it's also sometimes a question of finance and ease of the patient, but maybe you can comment on, since you have several types of fatty acid testing in your program?
I do think, so the first part of that question about red blood cell fatty acids versus the whole blood spot fatty acids, we ran some internal studies and found tight correlation between both. So I would interpret them the exact same way. Whether it's from a blood draw or whether it's from a blood spot, in other words. So I would interpret them the same way. The other part of the question about should I add that on or not, I think the decision for me is, is my patient, do they have an autoimmune condition or a chronic inflammatory condition or a personal history of cardiovascular disease or family history of cardiovascular disease? If they do, then I think it's worth the additional expense to add on the blood spot fatty acids, because I really want to make sure they have enough omega-3s and enough of the most anti-inflammatory omega-6. And I want to be able to see their risk for that. So I do think it's worth the expense in those cases. If on the other hand, if you have a patient where resources are very limited and they're getting omega-3s, they have a good amount of omega-3s in their diet, from fish to flax to walnuts to chia seeds, their diet's really good. In that case, and if resources are limited, that may be something to leave out, because they're getting good sources of omega-3s, or they're already taking a fish oil and they don't have any plans to stop it. In that case, you might say, well, we can skip the blood spot fatty acids for that patient. So it kind of depends on the patient, but that's how I think it through.
Totally, it's not that expensive adding it on, but of course, if finances are limited, it is. But just I don't think it's that much more. So patients are often, okay, well, whatever the amount is, okay, I'll add that, as long as you just explain it, and then they have come to you to get help. So maybe they prioritize it anyway. A question in regards to the lipid peroxidation marker. Well, I mean, what's the root cause for that being high? Because there's both, of course, the food that you're eating, the types of fats that you're eating, but then there's also this theory that if you are taking fish oil and you're not getting enough antioxidants, that will then the fat may go more rancid. And can you just elucidate a little bit more on that?
That's an excellent question. I always wonder about that in patients who have are taking a fish oil that's either poor quality or they're not caring for it appropriately, and it's exposed to light or heat, or it's been on the shelf a long time. Some of the lipids in that fish oil could be oxidized and may contribute to the elevation in lipid peroxides. So it's an excellent question. So definitely something to think about and something to evaluate with your patient if you're seeing very high lipid peroxides and they're taking a fish oil. The other part of that question about the sources of lipid peroxidation, I think of this as in two buckets. One is that they don't have enough antioxidants to protect their cell membranes, or two, they have too many pro-oxidants and like toxic exposures or things like that that are contributing to oxidation. And the pro-oxidants could be anything from toxic metals to alcohol, to smoke, to medications possibly that can create some oxidative damage, like acetaminophen or paracetamol. It could be things like poorly controlled blood sugar, or maybe dysbiosis and lipid peroxides, or lipopolysaccharides rather, in the gut. All of those things could potentially create a free radical that damages a cell membrane. So that's sort of how I think it through.
Super. Thank you. One is asking if you would kindly repeat why the glycine serine metabolites are important.
Glycine serine metabolites. Let me get to that page here. So glycine is it has neurotransmitter properties itself. It is an inhibitory neurotransmitter, and it is also part of the glutathione molecule. It's one of 3 amino acids that is used to build glutathione. And it is also one of the amino acids that we conjugate things to in the second phase of liver detoxification. So I look at that one as, if it's low, that's something I usually want to correct. And I've prescribed quite a bit of glycine for my patients over the years, and it seems to be always well tolerated. Occasionally, if the dose is very high for the patient, they might report feeling a little lethargic or a little air hungry, where they just have a little trouble, feel like they have a little trouble catching their breath. That would be something to look out for. But I've only found that to be true at very high doses. Serine it's a good question, because serine can be converted from glycine in some cases. They can convert back and forth. So in this particular case, it may be that serine's having trouble converting into glycine, which I believe is a magnesium dependent conversion. And it's one of the reasons why we look at elevations in these markers as possible indicators of magnesium need. In the support guide, you'll also see for things like low phosphoserine, which is also a result for this patient, that can be a sign of unmet needs for B6. It's one of 12 or 14 markers that contributes to the B6 recommendation. So when phosphoserine is low, could be an indication of a need for B6. And then sarcosine is also reported here. This is part of the methylation pathway. It's a metabolite of SAM. SAM is our body's main methyl donor. And in its conversion to SA, it can kick off sarcosine, which we don't have all of the answers about sarcosine at this point, but what I have seen is that sometimes when sarcosine is elevated, things like folate or B2 may be helpful to support that pathway and support methylation in general, which might help to lower the level. And it does have, sarcosine does have some associations with mood disorders as well. When it's elevated, I think depression, and I think it's even, there's mixed literature on schizophrenia, I believe, but sarcosine being high is something I think often balances out with the help of B vitamins.
Super. Just sitting here answering some questions, writing them down.
Excellent, excellent.
Because the question came up about organics and metabolomics, but
yes, organics and metabolomics. So the organics profile looks a lot like this in terms of the markers that we're measuring in the organics, but the organics kind of stops here, and you're just basically focused on the organic acids. So what you're not getting in the organics are the oxalate markers, and you're not getting the amino acids, and there's no opportunity to add on the fatty acids either for the organics. So it is a briefer version of the metabolomics. I find that the metabolomics is a little more helpful than the organics because you get organic acids in both tests, but even in the regular metabolomics without any of the add-ons, you're still getting the organic acids and the amino acids. So I find that the metabolomics is a little more helpful than the organics. The organics is still a good test, but it's just focused on the organic acids.
Excellent. Yeah, you do. As I wrote, I if possible, I have shifted to metabolomics, but it's a little bit more expensive, but you also do get a little bit more. It's like there's more pattern recognition, there's more like conversation. The patient engages a little bit more when you go through that report, because in an organics report, you just have the markers and that's it. But here they can, oh, A vitamin, they recognize that, and they recognize some of them, and maybe they remember that coconut oil has palmitic acid in it or something like that. And then, so you have a good conversation going there. But sometimes people can't afford it, and then, or they have done an organics before and you want to follow up on that, and then I stay with the organics test. So that's my point.
That's a good way to think about it.
I think that's it. No more questions. At least I might have skipped some, but guys, if I have.
Well, thank you again for having me, and Catherine, and thank you all of you for attending and sticking with us to the end of the presentation here. I really appreciate your time, and I hope wherever you are, you're safe, healthy, and happy.
Thank you very much, and thank you very much for your time, and I hope to see you soon again before the year is over, hopefully, on some other test or something. We'll see.
Sounds good.
Yeah, so, but we will keep you all posted, everyone. Remember, cross in the calendar on the 27th for the new Trujac cancer test. Don't miss it. And we, of course, will send out mailings with all the next webinars that are coming up that we are planning throughout 2022. And what else? We've got a funny, interesting things that we might want to share with you. I wish you all a lovely Thursday evening and the rest of the day. For you, at least, those of you in the US. For those of us in Europe, it's the evening, and for those of one the other way, it's a good night and sleep well. Take care, everyone.
Thanks, everyone. Bye-bye.
Bye.